In the spring of 1918, while the world's attention remained fixed on the battlefields of Europe and the thunder of artillery across the Western Front, a different kind of enemy was quietly emerging. It did not march in uniform. It carried no flag. There were no trenches to defend against it and no armistice to negotiate its surrender. Yet within 24 months, it would kill more people than the Black Death killed in a century. It would claim more lives than World War I. Before it finally burned itself out, this invisible pathogen would infect an estimated one-third of the global population and leave at least 50 million dead, with some scholars placing the toll far higher. The Spanish flu did not discriminate between soldier and civilian, rich and poor, victor and vanquished. It moved with indifferent efficiency, cutting across borders and battle lines alike. It simply killed, with a speed and ferocity that continues to haunt epidemiologists more than a century later. The pandemic's precise origins remain debated, but the most widely accepted evidence points to rural Kansas. In early March 1918, at Camp Funston, part of Fort Riley, a cook reported to the infirmary complaining of fever, sore throat, and headache. Within hours, dozens of soldiers presented similar symptoms. By the end of the week, more than 500 men were hospitalized. Military physicians, accustomed to seasonal influenza outbreaks in crowded barracks, initially showed little alarm. Influenza was common in winter and early spring. Most cases resolved within days. The outbreak appeared inconvenient, but not extraordinary. They believed they were witnessing nothing more than a routine complication of camp life. They were catastrophically wrong. The virus spread rapidly through American military installations. Fort Riley, Camp Devens in Massachusetts, and other training centers reported similar waves of illness. The conditions were ideal for transmission. Young men slept in close quarters, ate together in mess halls, trained shoulder to shoulder, and boarded crowded trains bound for ports of embarkation. The machinery of modern war had created a vast human conveyor belt. The United States alone was mobilizing more than 4 million troops. As these soldiers prepared to cross the Atlantic, they carried with them something far deadlier than rifles and artillery. By April 1918, influenza cases were appearing among American forces in France. British, French, and German units soon reported significant illness among their ranks. The trenches, already breeding grounds for lice, rats, and bacterial infections, became incubators for viral transmission. Soldiers weakened by malnutrition, exhaustion, and psychological stress proved especially susceptible. Yet military censors in the warring nations suppressed reports of widespread outbreaks. Morale was fragile. Victory was uncertain. No government wished to admit that disease was decimating its forces at a critical moment in the war. Spain, however, remained neutral. Spanish newspapers faced no wartime censorship and freely reported on the illness sweeping through their population, including the infection of King Alfonso XIII. As a result, international headlines associated the disease with Spain. The misleading label Spanish flu took hold, though the virus did not originate there. Spain's transparency created the illusion that the disease was uniquely Spanish, when in reality it was already entrenched across Europe and North America. The first wave of illness in the spring of 1918 proved relatively mild. Infection rates were high, but mortality remained similar to seasonal influenza. Most patients experienced fever, aches, and fatigue. Soldiers filled infirmaries, spent several days recovering, and returned to duty. The virus appeared to follow the conventional influenza mortality curve, striking hardest at the very young, the elderly, and those with compromised immune systems. By early summer, cases declined. Health officials cautiously suggested the worst might be over. Some believed the virus had simply run its natural course. They were mistaken. In August 1918, the virus returned in a far more lethal form. This second wave appeared almost simultaneously in 3 distant port cities, Freetown in Sierra Leone, Brest in France, and Boston in Massachusetts. The transformation stunned physicians. The virus had mutated into something unprecedented in modern medical history. Patients who seemed healthy in the morning could be dead by nightfall. Hospitals filled with men and women gasping for breath, their lungs overwhelmed by fluid. Autopsies revealed lungs so damaged they resembled those of drowning victims. The disease attacked with terrifying speed. Victims developed high fevers and severe pneumonia. Their skin turned blue from oxygen deprivation, a condition known as cyanosis. In some cases, blood seeped from noses and ears. What confounded doctors most was the demographic pattern. Previously healthy young adults between 20 and 40 years old died in astonishing numbers. This was the very population that typically survived influenza. Scientists now believe the 1918 strain triggered what is known as a cytokine storm, an overreaction of the immune system. Instead of simply attacking the virus, the body unleashed an uncontrolled inflammatory response that destroyed its own lung tissue. The stronger the immune system, the more violent the reaction. The very mechanism designed to protect the body became the instrument of its destruction. In cruel irony, youth and strength became liabilities. In late September 1918, Philadelphia hosted a massive Liberty Loan parade to promote war bonds. Despite warnings from medical officials about rising influenza cases, city leaders refused to cancel the event. An estimated 200,000 people crowded the streets. Bands played. Flags waved. Within 72 hours, every hospital bed in the city was occupied. Within a week, more than 4,000 residents were dead. The death toll mounted so rapidly that morgues overflowed. Bodies lay in homes and on porches, awaiting collection. Undertakers could not keep pace. Mass graves were excavated with steam shovels. Entire families perished within days. Orphanages filled with children who had lost both parents. Other cities responded differently, with varying results. In New York, officials closed schools, theaters, and churches. In San Francisco, authorities mandated mask wearing, enforcing compliance with fines and arrests. Seattle banned public gatherings and even discouraged handshakes. Indianapolis outlawed spitting in public. These measures slowed transmission in some regions, but enforcement was uneven and public resistance common. Despite best efforts, the virus continued its relentless advance. Rural communities suffered alongside urban centers. In remote Alaskan villages, mortality reached catastrophic levels, in some cases wiping out 90% of residents. Native American communities, already devastated by centuries of introduced diseases, endured mortality rates as high as 25% in certain areas. With limited medical infrastructure and delayed aid, entire settlements faced near extinction. Globally, the devastation was staggering. India suffered the highest absolute death toll, with estimates ranging from 12 to 17 million deaths. Famine conditions and wartime economic strain left populations especially vulnerable. Iran may have lost up to a fifth of its population. Parts of sub-Saharan Africa saw entire villages disappear. In Western Samoa, approximately 22% of the population died within weeks, bringing the island's social and administrative systems to the brink of collapse. By contrast, neighboring American Samoa imposed strict maritime quarantine and recorded 0 deaths, a rare example of successful containment. The war itself was influenced by the pandemic. Germany's spring offensive in 1918 coincided with widespread influenza in its ranks, weakening already strained forces. The Allies, bolstered by fresh American troops and industrial resources, were better positioned to replace their sick and dead. Some historians argue that the pandemic contributed to Germany's inability to sustain its campaign, hastening the war's end in November 1918. Yet the armistice celebrations that followed became new opportunities for viral spread. Soldiers returning home carried the virus into communities that had previously escaped severe outbreaks. By December 1918, the second wave began to subside, but the virus was not finished. A third wave emerged in early 1919. Though less lethal than the second, it still claimed hundreds of thousands of lives. It lingered through the spring before gradually diminishing. The pandemic ended not because humanity conquered it with medicine. There were no antivirals, no antibiotics for secondary infections, and no vaccines, but because the virus had exhausted its supply of susceptible hosts. Those who survived carried antibodies. The pathogen had burned through the global population with brutal efficiency. The aftermath was profound. In the United States, life expectancy dropped by 12 years in 1918 alone. The global death toll remains uncertain, with conservative estimates at 50 million and others approaching 100 million. By comparison, the entire First World War killed approximately 17 million people over 4 years. The influenza pandemic killed at least 3 times that number in less than 2. The social scars were deep. Millions of children were orphaned. Countless spouses were widowed. Economies already weakened by war faced further disruption. Yet remarkably, the pandemic faded quickly from public memory. Unlike the war, commemorated with monuments and annual ceremonies, the influenza left few memorials. Historians suggest this collective amnesia arose from trauma. The event felt random and senseless. There were no clear villains, no decisive battles, no narratives of heroism to anchor public remembrance. There was only grief. Medical science did extract lessons, though they took decades to fully integrate into policy. The pandemic underscored the necessity of international disease surveillance, transparent communication, and rapid public health intervention. It demonstrated that quarantine, isolation, and social distancing could reduce transmission, even if imperfectly applied. It revealed how swiftly a pathogen could traverse an interconnected world linked by ships and railways. In later decades,